I'm Ben Black. Welcome to my senior TED Talk. To get a quick poll of the audience, how many of you guys have broken a bone? Of those who have broken a bone, how many required surgery? While I've never broken a bone, the majority of fractures will need surgery. There are about 7.9 million fractures that occur each year in the US, and the most common treatment is surgery. There are a lot of different internal and external fixation devices used to treat fractures, so knowing how they affect you and whether they're beneficial or not is very important. For my senior project, I researched the question, what technologies are being used in orthopedic long bone trauma surgery, and what factors should be considered when deciding if it should be used. So, let's learn about long bones and fractures. To start off, I began my research by revisiting the anatomy, the biology, and the fracture healing of bones. This was pretty easy because I took a semester anatomy course here about 1.5 years ago, and I was actually able to go back through and revisit the original slides that I learned it on, and I was able to look through some books and just relearn them. But just so you guys have some context of what I'm talking about and what I'm referencing, this is a long bone, and to be specific, this is your femur, which is this bone. A couple other long bones in your body that I'll mention throughout my talk, just so you know what I'm talking about, is you have your femur, tibia, fibula, radius, ulna, humerus. I will mention those throughout my presentation, and so just so you guys have some context and aren't completely lost, those will help. And so just going to the actual bone anatomy, up here you have your proximal epiphysis, and then down here you have your distal epiphysis. Proximal and distal are common terms used in medicine to relate to the limb. Proximal is closer to point of attachment, and distal is farther away from the point of attachment. So this is my humerus, and my distal humerus attaches to my radius and ulna, while my proximal humerus attaches to my scapula and the glenoid cavity. Beyond that, moving in towards the middle, you have the metaphysis, and from there you have the diaphysis. In the diaphysis, you have this thing called your medullary cavity. In the medullary cavity, you have what's called yellow bone marrow fat. And try and remember the medullary cavity and that it's a hollow shaft in your bone, because I will be referring to that later when we talk about internal fixation devices. So the majority of my research consisted of me reviewing studies done by authors that were original studies, and it was looking at academic journals, and the authors also compared multiple studies and assessed it based on other studies and what they found. So, one of the two different fixation devices that I looked at in my project were internal fixation and external fixation. External fixation is when you fracture a bone and it's actually fixed through wires and pins which are drilled into the bone, and then this scaffolding apparatus, which you can see here and there, is attached to those wires and pins to keep it stable, and this actually holds the fracture together. You can see that these are both for tibia fractures, which is this bone, and they drill in after reduction is performed, and I'll explain what that is in a little bit. And these drill in and hold the bone together so that it can properly heal. This is a unilateral fixator because it's only on one side, and then this is a circular fixator or an Elizarov fixator. External fixation is most commonly used for lower extremity injuries, especially when there are multiple fractures or when there is large soft tissue loss. And this is a very minimally invasive procedure because they make very small incisions throughout, and there's not a huge scar or huge incision left over, like what happens in internal fixation. In internal fixation, a large incision is made, and from there they use an internal fixator device like a plate or an IM nail. I focus most of my research on internal fixation because it's much more popular and it's much more interesting surgeries to watch than external fixation by far. So, two very important two concepts that go along with internal and external fixation are reduction and malunion. To start, reduction is reducing the anatomical parts of the bone back to their original state. So pretend this is all one bone and it gets fractured and it gets off-ended like this. Reduction is done to move that bone back into place and reset it. This is a necessary part in fracture healing because if it's not done, this can result in very poor healing and very big deformities. Reduction is done through pulling traction back on the bone to reset it and put it back into place. This can be done one of two ways, closed and open. I've actually been able to see closed reduction in the OR at Mercy, which is where I have an internship. And it was really cool because it was a pediatric case and it was a distal radius fracture, and this is your radius. And after they put the kid under anesthesia, the surgeon shot fluoroscopy, which is like a video x-ray of the fracture, and it kind of looked like this. And through traction, the surgeon kind of manipulated the arm and actually pulled back and was able to reset it. And it was really cool because you could actually hear the bones cracking as they were set back into place. So it was a really cool procedure to see, and it was very interesting. Another way to do reduction is openly. A common term used in orthopedics is ORIF. ORIF stands for open reduction and internal fixation. So open reduction is done by actually making a surgical incision, and then you actually push back the pieces together and check it there, so you don't need x-ray, which they may take it in general just to make sure everything is lined up, but overall they're able to put everything back together right there. And then following that is an internal fixation device, and we'll talk about that in just a little bit. Following reduction, it's very important because if not, you can get what's called malunion. Malunion is when the bone ends don't line up and they actually start to heal like this. This creates a big problem because not only does this create mechanical instability, but it also can cause deformity. One example of this is this femur. This is your distal femur, which is down here, and it meets up with this bone called the tibia, which is this one. You can clearly see here, these are angles actually put in with x-ray technology, and these angles should be 0. You can see here that this angle is completely off and that this was a very poor reduction and healing job. This is what a normal femur should look like. You can see that it's smooth and pretty straight, whereas this one is very off. And that's what can happen if poor reduction is done, and this is when malunion occurs. Malunion, if caught early enough, can be fixed through more reduction, or if it's caught later, then revision surgery may be necessary to go back in and possibly re-break the bones or to get them back into the position that they should be in. Now that we know some of the beginning steps to fixation, let's look at the devices actually used. The first and most common internal fixator device is a metal plate. These metal plates are usually made of stainless steel or titanium, and they are individually sized for your bone. In the OR, they actually go in and they can measure. They have many different sizes of these different plates. This is for a distal radius fracture, so a radius plate. And they actually go in and they check the sizing so that it fits perfectly to your bone anatomy and so that it can be the most beneficial to you. As you can see, there are holes in them so that they can put screws, and depending on the stability necessary for the fracture, that may change how many screws they put in. Along with looking at metal plates, I also looked at 2 new technologies that are plates that are up and coming. So the first one was auxetic. Auxetic is a newer plate material that's a polymer, and it's a really unique design because if you look at it, and this is going to be kind of counterintuitive, but when you pull tension on it, it actually gets wider perpendicular to the forces applied. So when you pull tension, it gets wider, and when you compress it, it gets smaller. This is done because if you look at this design and how the squares are connected at the corners, that is when it's stretched, and you can actually see that it's wider because the tips point out. But when you compress it, the squares would become flush to each other, and it would get smaller. This is interesting. This is a unique design because one of the big problems with using metal plates is stress shielding. Stress shielding happens when your bones start to degrade and you have lower bone density. This happens because normal bones are strong because they have weight put on them. So inactive lifestyles can lead to lower bone density. But when you have a fracture, and say you have a plate in your femur, normal force is applied to that from your body weight, except when you have a metal plate, that force actually goes into the top of the bone, into the plate and around the fracture site, and then back into the bone. This leads to high stress shielding and low bone density. This solves that because while this is a flexible material, it does transfer some of that force and loading back into the bone so that it has low stress shielding and the bone is able to keep its density. Another interesting thing this does is it allows for micro-movement. Micro-movement is necessary for bones to heal, and it actually helps healing, which is where the bones barely move on the microscopic level and they touch ends, which helps and induce healing. The major drawback and limitation of this plate is that it hasn't been tested on animals or humans yet, and so there's no conclusive evidence that this works or even how it would work. It looks to be that you would screw in here and at the very end, or at the far end of it, but there is no way that we can tell yet if this works or not. But this may be implemented maybe 5 or 10 years down the line. Another technology that I looked at and researched was bioresorbable plates. These are commonly used in plastic surgery and maxillofacial surgery for mainly mandible fractures, which is your lower jaw. And these are really interesting because they actually degrade over time and they get absorbed into your body. This is really important and cool because along with stress shielding and that, basically as these degrade, it starts to transfer that or the force that would normally be going to the plate back into the bone. So this, along with auxetic, allows for low stress shielding. Another really important and key aspect of bioresorbable plates is that revision surgery isn't necessary. Revision surgery is pretty common with metal plates because you have to go back in and you have to surgically remove the plates and you have to take the screws, and it can cause for a pretty invasive procedure not only on your bones but also on your skin, and that's also more healing time that you have to undergo. These eliminate that because after a few months or even a year, this will be totally absorbed back into your body. The one limitation with bioresorbable plates is that they are not super strong, and so one of the academic journals that I was reading said it was relatively common to fracture your bone while using it if you took a fall or something, because they're not super strong. So while this is used in plastic surgery and maxillofacial, this definitely does have a clinical application to orthopedics if they're able to make this stronger. All right, the last internal fixation device we'll look at today is IM nails. IM nail stands for intramedullary nail. If you remember back to the anatomy of the bone, you have what's called in your long bones the medullary cavity. These rods that are usually made of titanium actually go into your medullary cavity and hold the bone together. After proper reduction is done, this is a femur fracture and that's a tibia fracture that they used IM nails for, and after proper reduction is done, they manipulate the leg in a way that they can actually put the rod down in it and have it sit in there. And this is a really effective way to heal the bigger bones in your body, like your femur, your tibia, and occasionally your humerus. I've actually been able to see 2 of these at Mercy, and they were really interesting to watch because they go in from the lateral aspect of the leg, and they make a few small incisions throughout, and they make a bigger one up here because this is where they put the rod. And they actually, after they make this, they angle your leg so that they can get like a straight shot down the medullary cavity, and then they actually start pounding. They pound it into your bone, which kind of aligns the bone pieces, and then from there it can heal like that, which you can see here. This is the fracture, and then that's where the bone went. And you can see at the proximal side they have a screw, and then at the distal side they'll have a screw too, and it can depend. I've seen upwards of 3 at the top and 3 at the bottom, but it kind of varies depending on the fracture and where the fracture is. So to recap, the 2 most common internal fixation devices used to treat fractures are plates and IM nails. Each of these require surgical incision, and each are very effective at what they do. So now that we're all orthopedic experts in here, I want to present the following scenario. Imagine this. Imagine that you are the only orthopedic surgeon in a small town, and it's the middle of the night and you get called in to do a procedure. The patient that you have to do surgery on presents with a proximal, meaning closer to the point of attachment, humeral fracture, this is your humerus, with comminution, which is in multiple pieces. You can see there's one here, there's one there, and there's another one there. And it's displaced, which means the bone pieces aren't lined up. So, what's your plan of action? My plan of action would be to first obtain radiographs like this and take an x-ray to observe the fracture characteristics and whether it's affecting the clavicle or even the scapula or even another part of the humerus. From there, do ORIF, which is open reduction internal fixation, and actually go in, do a surgical incision, put the pieces back together and reduce them, and then from there use a plate. One of the academic journals that I read talked about and compared the difference between plating and using an IM nail, and they actually found that for humeral fractures that it was more beneficial to use plates because IM nails cause chronic problems and shoulder stiffness and muscle problems, and so plates are actually more beneficial for humeral fractures. So use a plate, and from there do multiple screws to hold everything together, and from there suture up and close. And then check back with the patient to make sure malunion's not occurring and that everything's starting to heal correctly. So as I mentioned, fractures affect many people each year in the US. Knowing common technology and a specialty that you visit a lot, for example, cardiology, orthopedics, or even infectious disease, is very important because when you're able to understand and know why the doctor is using that technology that they're using and why it's working the way it is, you're able to have more informed, or you're able to ask them more informed questions, and you're able to understand it on a better level than you would be able to, and you're able to ask your doctor about possibly newer technology, like stuff that's coming out in orthopedics. So orthopedics is especially an important specialty to keep up to date with because most people throughout their life will have to visit an orthopedic specialist for either fractures, torn rotator cuff, arthritis in the knee, etc. And so staying up to date on medical information and a specialty that affects you is very important. So thank you all for coming to my TED Talk. I hope you enjoyed it and I hope you learned something.
Thank you, Ben. So we will take questions. Audience members, feel free to raise your hand, ask questions, and then panelists as well.
Do IM nails inhibit bone marrow growth and blood cell production?
To a certain extent they do, but actually most blood production is done in other parts. Here, I can go back to... most blood cell, or most red blood cell production is done up here. This is yellow bone marrow, which is fat, and that's where it stores minerals and stuff like that. But one of the big problems that I actually read with IM nails, and I read a couple different articles on reaming versus unreaming. Reaming is actually when they go through and they widen the medullary cavity, which is kind of invasive because it can cause more disruption of the bone around it. But it has been shown to be more beneficial, even though it kind of takes the cortical bone and disrupts it more. Lori?
It seemed like when you were talking about the reabsorbable plates, those seemed like they had a lot of benefits. Are they used for long bone fractures? And if, to what extent and why not? What are the downsides of those? I guess I'm asking.
The biggest downside, at least that I read, I read one article about this, and they did a study, it was about 5 or 10 years ago, and they used them for pediatric cases of long bone fractures, and they were for specifically femur fractures, and that was the only time that they mentioned that they were used for orthopedic fractures. But I think the main piece that's wrong, or that doesn't work very well with those, is that they're not very stable, and it's not a super developed technology right now. But the main point of those is to eliminate revision surgery, and that's why they use them for plastic surgery, and so you don't have to go in and make more incisions and have more healing.
So if it's like your femur where you're bearing weight on it all the time in a pretty massive way, they might break down.
Yeah, but that's also why they used it for the pediatric cases, because with pediatric cases, you don't want to have to go in and keep making incisions, and you want the bones to be able to continue to grow, so it's actually pretty useful for that. Katie?
So, are there certain techniques you would? Well, obviously there are, but answered my own question. I'm curious how these are affecting growth plates when you're using because when you're a kid and you have growth plates and you're still growing. obviously the IM nail might be too invasive, you know. So like I guess kind of what's your take on like
that?
how it's
I didn't
affecting
read a
that?
lot about that, but what I did read is that IM nails aren't super beneficial to pediatric cases because they have growth plates, and that can actually inhibit some of the growth with that. And so even for femur fractures, which are rarely plated due to all the muscle and soft tissue you'd have to go through, they did use them in pediatric cases for that reason, that they didn't want to disrupt the growth plates.
Did they use the like titanium ones, or did they use the like bioresorbable or whatever those ones were?
They mainly used the metal ones.
Okay. Nice.
Corey?
Is the biggest reason that internal and external mechanisms are used, like internals use like upper extremity and externals lower extremity, is that just because of like accessibility?
It can kind of change. If there's multiple fractures, and external fixation is mainly used for lower limb, but if there's multiple fractures, like say to your femur and your tibia, and you have soft tissue damage, they'll probably use an external fixator because it allows for minimally invasive, because your body's already experienced a lot of trauma, and so to go in and do more trauma on it can increase the healing time and cause more pain to your body. But internal fixation devices are used for lower limb and upper limb. So, Kyle?
You're talking about these in their applications, when they're good, when they're not. Like, what are the metrics for knowing if something worked or not?
For like when to use it, or
Yeah, I mean, so if you're looking at two different applications, two different technologies in a similar experience,
yeah.
what would be criteria we would use to evaluate which one worked better?
That's kind of one of the things. Is like I kind of had trouble with this with my thesis because I can't really give one specific answer for if you fracture this bone, like do this. It's not like a one answer thing, but it kind of depends a lot on not only the bone fracture, where it's fractured, the fracture type, and soft tissue damage are some of the bigger concerns that go into deciding what's used.
So I guess my question is, how do I know if it worked or not?
Like, what are you looking at? Like healing time? Are you looking at like,
Healing
patient,
time
like,
mainly, and chronic or not having chronic problems arise later in life.
So like long term.
Yeah, long term and short term healing. Christine?
I'm curious about the case that you presented that failed. If you know which method they used, and then how they fix it. If it didn't work. Your femur that healed.
The angle more.
Oh.
Yeah, that had the angle.
It's actually kind of hard to tell because I'm not totally sure based on just that picture of what was used, but I have seen the removal of an IM nail, and that's pretty crazy because they actually hammer up, and they like hammer. You can like. They like it's actually like all of the surgeon's force to hammer that thing up and out and to get it out of there because it's like very enveloped in there, and so I'm not totally sure what was used for that case, but it was a pretty poor job.
How do they fix it?
I kind of doubt that they would fix this. This isn't hugely deformed, but. Yeah, I don't think they would fix that because it still works relatively well and it's still relatively straight, but it definitely doesn't have the mechanical strength that a normal femur should.
But so like if it were kind of ridiculously at an angle.
Yeah.
Like how
and usually they can catch that stuff.
What would they do if they caught one that was broken like that? Would they just re-break it, or?
They could, if depending on the healing stage, they could go back in
and actually
manipulate it there through reduction. Morgan?
So I have two quick questions. First one is, what is the process they use to re-break bones to reset them? And then the second one is, what are the bioabsorbable plates usually made out of? Or what are some of the different types of that?
Okay. For your first question, I'm not exactly sure. I actually haven't researched that or how they break bones and like go back in and do that stuff, so I can't answer that. But the second one is there's different compounds that they make the bioresorbable plates out of, and there's different kinds, and they're able to alter it depending on the amount of time necessary to heal the fracture. But I'm not exactly sure what they're made of, but it's some type of biodegradable material that's safe and can be absorbed back into your skin.
So for instance, would they use like a mixture of different minerals usually found in bones, like
it could be,
calcium and
yeah.
other things?
which is also kind of one of the, or like it's tricky because they can't just put an easy biodegradable thing in there because it has to be safe for your body and it can't cause like a foreign body reaction or other things like that.
I think on that we should
Yes.
wrap up.
Thank you very much,
Thanks,
Ben.
Yep.